Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. If you like my lectures, please don't forget to press button like, subscribe, and you can press a bell icon so that you can get a notification for next lecture. Today in continuity with some of the odd disorders we call rare disorders, but they are quite common, which we miss good number of time in our everyday practice. And one of those disorders in children is hand, foot, mouth disease. In short, we call as Hfmd. So today we'll be discussing on that topic we call as hand, foot, mouth disease. Short form Hfmd. We'll be discussing under those common headings: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment, and complications. Now, heading itself gives you a very simple way to understand that it involves hand, foot, and mouth. Now, this particular disease is an infectious disease which causes a rash on hand, foot part, and mouth. Etiology of this is by Coxsackie virus A type 16, which is a single-stranded RNA virus. There are other viruses also, which can be A5, A7, A9, A10, B2, B5, or enterovirus 71. It is worldwide, but the most common in children between 5 to 10 years, particularly where there is a good group of children like daycare, summer camps, and good number of time within families. These particular disorders, that is hand, foot, and mouth disease, they are seen more in summer and early autumn. So, in brief, it is a brief febrile illness. You see a typical vesicular rash, which are mainly seen on the palm, on the sole part, may be seen also on buttocks, and in a oropharyngeal area, in the form of ulcers. First case was reported in New Zealand in 1957. It is almost benign and self-limiting, but once in a while it can produce some complication which can be deleterious and can have mortality. We have already told you that the commonest age is 5 to 15 years, so it is very common in that particular group of children. Already in etiology we have mentioned Coxsackie virus or enterovirus, and mainly the route of transmission is fecal-oral route of transmissions. It is more common in a daycare area, summer camps, within families, and we already mentioned that it is common in the children under the age of 10 years, usually between 5 to 15 years. So it is basically an enterovirus, mainly Coxsackie virus, A16, maybe 4, maybe 7, maybe 9, 10, and enterovirus 71. The route of transmission is fecal-oral route, which will lead to viremia and invasion of the skin and mucosa. Initial viral involvement is invasion is the oral mucosa and ileal mucosa, and it is followed by a spread to the regional lymph nodes within 24 hours. Incubation period is approximately 3 to 7 days. So you can see that it enters through the oral cavity and mainly by the means of contact with the body fluids, direct or indirect method. The main route of transmission is the fecal-oral route. Virus will be shed in the stool for a week or so. Incubation period is from 3 to 5 days, then you get a lymphadenopathy, and then virus will involve skin of palm and foot. That's why hand and foot, and oral cavity, oropharyngeal area. As far as the clinical picture is concerned, there is a prodrome phase in which you get low-grade fever, malaise, symptom signs of sore throat in the form of cough, pain, ulcers. Some children can complain of abdominal pain, and because of oral ulcer, difficulty in eating, sore mouth, and general body ache in the form of myalgia. Skin of hand and feet are involved, and also oral mucosa is involved. This particular rash is described as exanthema, which involves hand and feet, and followed by oral ulcers. Skin lesions are characterized by erythematous macules or papules in the initial stage, which are mainly seen on the palm, hand and soles, palm of hands and soles. Sometimes it can be also seen on the buttocks and or on genitalia. These are usually red papules, superficial. They are seen as vesicles. In a few days, mainly on the palm and sole. So in a prodrome stage, fever, sore mouth, pain in the throat region, reduced appetite, malaise, abdominal pain. Some children may have even nausea, vomiting, and we know very well it is by either enterovirus or by Coxsackie virus. Fever, throat pain, reduced appetite, malaise, and abdominal pain. The rash appears in a crops, persists in a group, mainly over the palm, feet, and perioral area, may be seen over the knees, buttocks, and inner oral cavity, oropharyngeal area. You will see a vesicle, and that may be, there may be erythematous papules. Lesions are elliptical in shape, with the long axons running along the parallel to the skin lines, and may be asymptomatic, and in some they are painful. They disappear within 5 to 10 days without scarring. This is very, very important. Well, in case of a chicken pox and smallpox, there are some scarring, mainly in case of smallpox. Among the oral manifestation, patient will complain of pain in throat region, sore throat, and because of those ulcer, even dysphagia. Multiple vesicles and ulcer are seen on the affected part in the oral mucosa. They are shallow, painful, and they are small ulcer. Commonest sites are tongue, buccal mucosa, and hard palate. Gingiva are rarely involved. Oral lesions will resolve within 7 to 10 days. By and large, we say within 1 week. So, eruptive vesicular rash. 1 or 2 days after the fever. So fever is followed by a rash, which are mainly vesicular or pustules on erythematous base. So we call erythematous rash. Mainly seen over the tongue. See, this is the tongue region, buccal mucosa and hard palate. And you can see perioral region also. This is the sole part, this is the palm region. And you will see in an oral cavity. May be seen on the posterior area of the mouth, hand, feet, sometime also in the buttocks and genitalia. So these are the rash you can see clearly on the hands, foot part, perioral region, oral cavity, tongue with low grade fever, reduced appetite, general malaise, and mainly the symptoms are because of the mouth ulcer, which will give rise to pain in the throat region, dysphagia, decreased appetite, and some children might have even nausea, vomiting. Classical rash, you can see perioral region, palm, foot, we call sole region, which are mainly macular regions, maybe vesicles, and will be erythematous, halo, erosion on erythematous halo. So, and later on it can ulcerate. Mainly you will see more in a case of an oral ulcer rather than the hand and feet ulcer. And there will be no scarring. So vesicles are surrounded by a thin halo of erythema, eventually rupturing and forming a superficial ulcer with a green-yellow base and erythematous rim. The exanthema, widespread rash, macular, papular or vesicular, non-pruritic, by and large non-painful, occasionally painful, mainly seen in the dorsum part of the hand, that is the palm, sole, buttocks, legs, sometime on the arms. Rare presentation, very rare, is aseptic meningitis. Very rare. Diagnosis is mainly by a clinical features, mainly in the form of symptoms and signs, and you can detect a virus in the stool for about 6 weeks after the infection. So mainly a clinical diagnosis, and you can try to isolate the virus by using a swab from the stool or from the infected area by PCR, or demonstrating a serological test in which you demonstrate the antibody against viruses. Main differential diagnosis is chickenpox, acute herpetic stomatitis, minor aphthous ulcer, and herp angina. As far as treatment is concerned, it is mainly supportive and symptomatic. So it is a self-limiting disease within 7 to 10 days. Mainly you will have to give lot of fluids because person finds difficulty in eating because of painful ulcers. So you will have to give lot of fluids. Avoids food which irritates the lesion, oral lesions. If person is having fever, antipyretics, and pain relief can be by antipyretic like acetaminophen, or you might have to use ibuprofen, mouthwashes, etc. IV immunoglobulin may be used in a person in whom you might get a possibility of aseptic meningitis, etc. Antiviral drugs are usually not effective, but in a complicated patient, antiviral drug can be tried. So there is neither an effective antiviral drugs nor an effective vaccine available against this disease. Because it resolves within 7 to 10 days, Mainly the simple treatment is supportive, which is in the form of antipyretic, analgesics, lot of fluid intake, person should be well hydrated, and you can give for oral ulcers liquid preparations of anti-inflammatory analgesic like ibuprofen. You can use liquid like diphenhydramine and can be used for gargle. Topical anesthetic can be used to reduce the pain in the throat region. As far as prevention is concerned, because it is a contagious disease and potentially spreads very fast over a large population in the community, particularly where the children get together. So the spread of the disease can be prevented by taking a precaution against the fecal-oral route transmission. So strict implementation of monitoring cleanliness of hands, utensils, drinking water, avoid direct contact with the affected people can be rewarding. Restriction of the affected children from attending the school or other outdoor activities by which they can easily spread this disease to the other children should be taken care. As far as a complication is concerned, they are absolutely rare, but still chance of aseptic meningitis, encephalitis, encephalomyelitis, acute cerebellar ataxia, transverse myelitis, GBS, opsomyoclonus syndromes, benign intracranial hypertension, etc. are possible. Hence, you should take care of the children who look sick, and you should keep it in mind that this type of complication can occur, but no doubt they are rare, but they are some of the complications in these hand, foot, mouth disorders. Most likely chance of some of these complications are by Epstein-Barr virus rather than Coxsackie virus. So Coxsackie virus infection are usually self-limiting and improve spontaneously within 7 to 10 days without any complications. In a rare cases, the patient may develop neurological complications such as encephalomyelitis, aseptic meningitis, or acute flaccid paralysis. These are very common with what we call as enterovirus 71. No doubt this is not so very common, but good number of time you will see in a children. If it is in your mind, you will be able to pick up and you can prevent a spread to the another group of children. So I feel this will be helpful to you in your everyday practice. If you like this lecture, don't forget to press button like, subscribe, and you can share with your friends, and you can press a bell icon so that you can get a message for next lecture. So thank you again for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. Thank you once again. See you in next lecture.